Professor Yasser Banna, Professor of Neurosurgery, Alexandria University, is going to present on arthrodesis to L5 versus S1 in long segment fixation, literature review, and personal experience.
Bismillah ar-Rahman ar-Rahim. I present my personal experience and the review of literature about this issue. What's long segment fixation? It's 4 or more levels. And what are the indications for long segment fixation? Adult spine deformity, multiple levels degenerative disc or lumbar spinal stenosis, intractable disabling pain, neurological disability, and affection of quality of life. The goal of surgery is usually to achieve neural decompression, correction of deformity, and restore the balance of the spine in both coronal and sagittal planes. To stop at L5 or to stop at S1. Those who are with stopping at L5 are aiming at motion segment preservation. And those who are with inclusion of the L5 S1, they are worried about the distal disc disease. And so when it is mandatory to fuse the sacrum, this is what's written in the literature. L5S1 spondylolisthesis, L5X1 fixed sagittal imbalance and the disc degeneration not matching the patient's age, L5S1 previous laminectomy, and L5S1 spinal stenosis. But in my hands, the first and second point only are the absolute indication for inclusion of the L5S1, but previous laminectomy and L5S1 stenosis in my hands do not mandate inclusion of the L5S1. So what are the biomechanical indications? If there is sagittal imbalance or a lumbar hypolordosis, pelvic incidence less than 48, sagittal vertical axis more than 4 centimeters, and sacrofemoral distance more than 5 centimeters. And those patients who are with long follow-up period with you, coming to you, many visits complaining of back pain, and those who are heavy labor. What are the concerns about fusion to the sacrum? It's a bigger operation, increase the incidence of complications, subsequent degeneration of the sacroiliac joint, alter the gait mechanics, and of course, high incidence of pseudoarthrosis. Here we can see a case with long segment fixation. The pseudoarthrosis written in the literature is 24% of the patients. And we can see here that the S1 screws, there is halo around the S1 screws, means loosening of the screws. What's the main cause of this loosening? It may be in part that the spine is resisting having no motion at this level. And so this level is very important for the body. And if you are squeezed in a corner and you have to fuse and include the L5S1, you have to have these precautions in your mind. Use 7mm diameter screws. Don't begin with the 6mm. You have to achieve the maximal medial inclination you can, and don't be worried. You will never hit the S1 screw. You will never hit it, because the diameter of the S1 pedicle is very large. You have to have tricortical screws piercing the posterior cortex of the pedicle, the anterior cortex of the sacrum, and the superior end plate of the sacrum. Interbody fusion, whether anterior or posterior, adequate preparation for the end plates, and the fluent bone graft, and don't depend on the small amount of bone that you place in your cage. What are the pros of L5 fixation? Shorter, less blood loss, preserve a motion segment, less risk of PGK and DGK, and loosening of L5 screws are much less than loosening of S1 screws. What are the concerns about stopping fusion at L5? There are some hazards. Yes, it's a tenuous fixation. Subsequent degeneration at L5S1 might occur, but most of cases it is asymptomatic. Of course, assessment of disc degeneration by MR, CT, plane radiography. This is a very large study, meta-analysis with comparison of long fusion terminating at L5 versus the sacrum in treating adult spine deformity, and they conclude the following. Stopping at L5, you have lower rate of pseudoarthrosis, lower rate of implant-related complications, and lower rate of PGK. Stopping at the sacrum, you can achieve better restoration of the lumbar lordosis and maintenance of the sagittal balance. And they are similar in scoliosis correction, overall complication rate, revision rate, and improved in pain and disability. This is a case with lumbar spinal stenosis, many levels. And we can see here that the disc at L5S1 is looking very good. And so, and also this is the AP and lateral X-rays. We can see here degenerative scoliosis and lost lumbar lordosis. And here is the surgery leaving the L5S1 version. And here is the post-operative X-ray. And this is 3 years follow-up. Nothing happened to L5S1 and no loosening of any screws at any level. This is another case with multi-level spondylolisthesis at L3-4, L4-5, and L2-3 maybe, and degenerative scoliosis. And the surgeon here included the S1, and we can see loosening, backing of the screws. He didn't perform any interbody fusion here. He depended on the posterolateral fusion, which is very, very weak. My take-home message, what is written in the literature is stopping at L5 not frequently leads to subsequent degeneration at L5S1. In my humble experience, stopping at the sacrum is a bigger operation, increased short-term complications, increased pseudoarthrosis rate, high incidence of sacroiliitis. Stop at L5, except you have L5S1 spondylolisthesis or severe sagittal imbalance. Decision should still be taken on a case-by-case basis. I thank you very much for this.